Hello, my name is Leo. I'm an intensive care doctor working in the UK. Hope you're well. In this part 1 video, I'd like to discuss etiology, pathophysiology, clinical features and investigations of left-sided heart failure. Acute left-sided heart failure is a common reason for hospital admission, and it is related to significantly increased morbidity and mortality. Normally, patients with acute heart failure could be managed in coronary care unit. However, they are frequently admitted to intensive care unit when associated with multi-organ failure. Acute heart failure can be presented as new onset heart failure or as decompensation of pre-existing chronic heart failure. Coronary artery disease, atrial fibrillation, and hypertension are common cardiovascular comorbidities of heart failure. Non-cardiovascular comorbidities include diabetes, anemia, COPD, and renal failure. Now, let's talk about causes of left-sided heart failure. They can be divided into ischemic causes and non-ischemic causes. Acute myocardial infarction is the notorious cause of heart failure due to the irreversible loss of myocardial function in the infarcted area of the affected coronary artery. Ischemic myocardial dysfunction can be reversible when it is caused by myocardial stunning. If a patient presents with features of acute heart failure several days following a large acute MI, we should suspect mechanical complications such as papillary muscle rupture causing acute severe mitral regurgitation or rupture of the ventricular septum leading to septal defect. Non-ischemic etiologies like cardiomyopathy, for example dilated or hypertrophic cardiomyopathy, peripartum cardiomyopathy, and Takotsubo cardiomyopathy, arrhythmias like atrial fibrillation with rapid ventricular rate, acute viral or inflammatory myocarditis, infective endocarditis with acute valvular insufficiency, and sepsis-induced global myocardial depression are the causes that we should consider in patients with acute left-sided heart failure. Non-cardiac causes such as pheochromocytoma and bilateral renal artery stenosis could lead to severe hypertension, causing pulmonary edema and acute heart failure. Now, let's move on to the pathophysiology. Acute heart failure is in fact the response to reduced cardiac output or increased cardiac load caused by impaired cardiac function secondary to the factors which I aforementioned by compensatory hyperactivation of the sympathetic and renin-angiotensin systems. As a result, the clinical picture of vasoconstriction and fluid overload occurs. Moreover, myocardial oxygen demand becomes a lot higher due to increased left ventricular workload and cardiac congestion secondary to raised left ventricular end diastolic volume and pressure. Coronary blood flow may also be diminished by systemic hypotension and elevated myocardial wall stress. Unless the underlying cause is treated, this compensatory mechanism will create a vicious cycle by worsening preload and afterload of the heart and will ultimately lead to further deterioration of cardiac function and systemic perfusion, resulting in a downward spiral into cardiogenic shock. The left-sided heart failure will increase the intravascular pulmonary pressure and subsequently push the plasma out of the pulmonary vessels into the interstitium and alveoli, leading to acute pulmonary edema. This mechanism can cause significant impairment of gas exchange and respiratory failure. How do patients with acute heart failure present to us? Well, the symptoms of acute left-sided heart failure are mainly driven by congestion and low cardiac output. The features of cardiac congestion, such as shortness of breath on exertion, leading to poor exercise tolerance, orthopnea, paroxysmal nocturnal dyspnea, waking the patients from sleep, cough with pink frothy sputum, and dependent edema are common. Furthermore, symptoms of underlying causes, for example chest pain, palpitations, etc., could be present. During physical examination, the common signs are tachypnea, raised jugular venous pressure, tachycardia, gallop rhythm with third or fourth heart sound, cardiac murmurs, and bilateral crepitations. features of pleural effusions can also be found. Patients with cardiogenic shock could be hypotensive with a systolic blood pressure less than 90. Capillary refill time will be prolonged with skin mottling due to poor peripheral perfusion. Oliguria and confusion could occur as a result of impaired major organ perfusion. The onset of decompensated chronic heart failure can be insidious, with symptoms worsening over weeks or months. On the other hand, patients with acute myocardial infarction or post-MI patients with mechanical complications can become acutely unwell over a few hours. To investigate patients with acute heart failure, we can start with routine blood tests such as full blood count, UNEs and creatinine, liver and thyroid function tests to identify causes of aggravating factors and to assess end organ functions. Specific blood tests include cardiac troponin and BNP. Although raised troponin level indicates non-specific cardiomyocyte damage, it is a powerful prognostic marker in patients with acute heart failure. I explained it a bit more in my previous video about acute myocardial infarction, so if you'd like to take a look, please click the link in the description. Plasma B-type natriuretic peptide is recommended to diagnose and prognosticate acute heart failure. BNP levels can be influenced by conditions. For instance, the levels could be higher in patients with renal failure, or they could be reduced in obese patients. If we suspect cardiomyopathy as the diagnosis, specific screening tests like ferritin, autoantibodies, and virus serologies for cytomegalovirus, Coxsackie virus, HIV, hepatitis could be done. ABGs can hint tissue hypoperfusion by demonstrating high lactate and metabolic acidosis. 12-lead ECG is rarely abnormal in heart failure. It is more useful to exclude arrhythmias and to detect new signs of ischemia or infarction. It is important to compare previous or baseline ECGs if available. From radiology point of view, basically, we can request chest X-ray to look for any classical signs of left ventricular failure, such as alveolar edema, Carly-B lines, cardiomegaly, apollo vein diversion, and pleural effusions. Echocardiography is the most useful and widely available imaging in patients with suspected heart failure. It can assess ventricular function, chamber size, wall thickness, valve abnormality, fluid status, and the presence of pulmonary hypertension. Coronary angiogram should be performed urgently in patients with ST elevation myocardial infarction or ischemia-related cardiogenic shock. Right heart catheterization or pulmonary artery catheterization is not routinely recommended by European guidelines. However, it could be done to figure out left ventricular filling pressure by pulmonary capillary wedge pressure. Moreover, cardiac index, pulmonary vascular resistance, and mixed venous oxygen saturation could be calculated. Patients with acute severe heart failure will require close monitoring of cardiac output in the CCU or ICU setting. Repeated echocardiography, pulse control cardiac output PICO studies, lithium dilution cardiac output LITCO monitoring, and pulmonary artery catheterization are techniques that we could utilize to determine if the patient is responding to our treatment. With regard to prognosis, generally, increasing age, male gender, low systolic blood pressure, renal dysfunction, pneumonia, and socioeconomic deprivation are predictors of poor outcome. CLIP scoring system is a validated prognostic tool as a predictor of 30-day mortality in patients with acute myocardial infarction. If there are signs of cardiogenic shock, the 30-day mortality could be around 80%. The survival after venous arterial ECMO score, SAFE score, is a validated international in-hospital survival prediction scoring system for patients with cardiogenic shock requiring extracorporeal membrane oxygenation support in specialist cardiac centers. Factors associated with a higher score and increased mortality include chronic renal failure, lower serum bicarbonate, lower pulse pressure, congenital heart disease, pre-ECMO organ failure, pre-ECMO cardiac arrest, and longer duration of mechanical ventilation prior to ECMO initiation. That's all for me in this video. In part 2 video, I'll talk about the management of acute left-sided heart failure. See you in the next video. Take care.